Good afternoon. I'm Lorraine Rosamilia. I work with the Geisinger Health System. I'm a dermatologist practicing in State College, Pennsylvania, home of Penn State. So today we're talking about zoster, and before we get into it, we'll look at some pictures because, as you probably know, even if you don't see patients every day, if you are a human who works in healthcare, someone is going to ask you about shingles and they're going to want to know the answers. And so to be interactive, please tell me which one of the pictures here do you think is zoster? Anybody? Mm-hmm. The answer is none of them. And so we're going to go through some of the cases today to describe just clinically, because we all are clinicians or researchers or people who know a lot about skin, a lot about how it works, and we still have a lot to learn. I learn every day when we see skin. And so tell me which one of these is zoster. I've biased you. Yeah. The answer is all of them, we've learned. So exact opposite. And so the cases today in these photos we'll talk about so that we can learn more clinically about them. And really the advent of this talk is the advent of most of my talks is to put a Post-it note pad next to my computer when I'm charting. And if I find that there's a question that keeps being asked that I can't answer, or something that I get in terms of questions from family members, or on consults that seems to be constantly misunderstood, that's a great topic for a talk. And I think zoster certainly fits in that category when it comes to treatment, prevention, and the vaccine. And so all of it will be case-based. All of them are my cases. And if you happen to fall asleep or in some sort of hunger coma, then the New England Journal article in 2013 and my references and also the Zostavax package insert are good first steps to understand this better. So my first is a 72-year-old otherwise healthy male. He has painful bumps along the back and thinks he may have been bitten by a spider or a tick. And you tell him it's shingles, he wonders how he caught it. And so I think that a lot of people ask this question, and in a classic distribution, I think all of us would be able to tell him that it is zoster, but sometimes explaining it to people can be a bit difficult. And if you're in clinic, you can't have a day or two that a person doesn't think they got bit by a spider. You know, all bites they think are spiders. And so it's important to tell them what happened and how they caught it. And so I think the best use of talks to other clinicians is to give them ways to explain your spiel to patients. And for me, pictures help. And I think to understand zoster, you have to understand the primary varicella infection, that is true infection, that is communicable, and also understand that the body stores it, forms an immune system response to it, and then is reactivated. So in very simple terms, it's not necessarily an infection when zoster comes, but more of a reactivation of something that your immune system has handled while your immune system was taking a nap. And what we've realized is that there's more and more reasons why immune systems take a nap these days when it comes to medications and immunosuppressive comorbidities. And I think these photos are helpful because it shows you not only the macro picture, but also in the spinal column how you would get sort of your initial infection, store it, and it's reactivated. So just to give you our spiel. And I think pictures like this are important because it shows you that the central nervous and peripheral nervous system are complicated. And when it comes to zoster, once it does have that little immune system nap, this is why so many systems can be involved, or the reason why once you get it under control, it can be under better control if it's treated appropriately. And I think the dermatome map is always something we need to remind ourselves of so we can explain to patients why we think that it might be shingles or why we don't, and why some of those photos in my first slide might be mimickers. So my first take-home point, I like to make things simple. So after every case, you're going to have a new take-home point, is pathophysiology matters, meaning if you understand how the virus works, then you understand how to make it simple to explain to patients. Second is an 81-year-old female. She's a new patient to you, but she came in with a rapidly evolving painful and pruritic eruption on the right cheek for a few days. She is unsure of her med list. So you also can't go through a day in clinic without someone who might have an elderly relative or patient who comes in who has absolutely no idea what medicines they're taking or what they're putting on their skin. So I think it's an important point that you might not have the full picture when you see them, but you have to use your clues. And so in this differential, we look at her exam, and then you take out your dermatome map. And you see, she doesn't really fit into something that would be classic for a V distribution. She's sort of spanning a few and has kind of a geographic pattern or a geometric pattern, or an outside job might be the reason. And so this would be more of a classic V3 zoster, where we've got sort of this nice beard distribution and some ear involvement. She doesn't fit that picture. And then this is a patient who has used F-Fudex on his nose, and it crossed the midline. He thought he had shingles, but this is, again, an outside job, an outside medication, and when you look at your dermatome map, you can see why. It's crossing several dermatomes, has more of a geometric shape to it, and this would be more of a V1 zoster distribution that would be classic. This patient has a nickel allergy, but again, people think that things that look like they might be on one side of the body, or they might look like a shape, could be shingles or might be in a line, but in this case, this gnarly belt is obviously the cause. And in this case, another shape, which was a benzoin allergy in a patient, was a contact dermatitis. So you can see why some of these cases might be confusing, but in this case, it was actually another patient who was using fluorouracil topically, or F-Fudex, and that she didn't remember which cream she had been given by which physician when she saw us, and it was a mimicker. So second point is that physical exam matters. In addition to your pathophysiology, if you look at your dermatome map, it can help you explain what to do. Next case, 24-year-old ill-appearing African-American male presents to the clinic with rapidly spreading tense vesicles all over his body. He's febrile, cannot walk because his painful lesions on the plantar surface prevent him from doing so. So this was the rest of his exam. He didn't want to get undressed, but we finally talked him into it, and what we found is that there were some linear patterns to his exam, and as you can see on the genital picture here, actually a very sharp cutoff when it comes to laterality on the body. So you had the picture that there was something that was dermatome-based, but at the same time, it was a very extreme case. So he was seen by urology. They told us he had molluscum, which, to us didn't make any sense. So when we saw his exam and saw that he was sick, we look at our dermatome map. So just to prove to ourselves that it follows some dermatomes, but it's crossing 3, 4, 5 of them. And the first time that I started working on this talk, I was working on an airplane, and I was trying to turn my screen so the genital pictures weren't out there for everyone. And I realized that it was dark and it was reflecting off the window. So we'll put that there just to make everyone more comfortable. And so the S distribution, in addition to some of the L distribution, especially on this patient's foot where he was very symptomatic, told us he had disseminated zoster, and he was young. And so it was his presenting form for HIV diagnosis, and he actually passed away soon after. Disseminated zoster can look like lots of different things from an iatrogenic standpoint for people who are on chemotherapy for cancer, which is this patient right here. And because often they're thrombocytopenic, their exam looks more purpuric, where you might mistake it for a vasculitis or other autoimmune phenomenon. But in this case, you use your clues that it looks like something vesicular, you follow the dermatomes, you look at his history, and you can see that it's his disseminated zoster, which can also have a verrucous form, which is much harder to diagnose because the testing methods to look for virus, for PCR, just has fewer organisms in general, and so it can be something that's more of a chronic form. So next point is that think about immunosuppressive comorbidities, because it might be the presentation of something infectious like HIV or some other immunosuppressive condition. Next case is a 30-year-old female who at 28 weeks, while she was pregnant, had true chickenpox, so had varicella, with diffuse vesicles all over her body, and her daughter is born at term with no complications, but at age 9 months as an infant develops a T3 rash, so you can see right up here. My only point with this case, pediatric zoster and pediatric herpetic infections could be certainly 6 talks all on their own. But my point here is just to say that third trimester true chickenpox actually is not as big of a deal for the mom as it would be if it was in the sooner trimesters, and that basically the fetus is exposed to true varicella. So it's almost like the fetus got chickenpox, but it was still protected by maternal antibodies until about 9 or 10 months of age. But because they got sort of a dulled immune response to their first chickenpox, they got zoster before they even turned 1 year old. And so my big point is that kids can get zoster if they're exposed in this way, or if they have other immunosuppressive phenomena in their childhood, or just because. So my point is, usually I do test them because people assume it's HSV, and it's not always. So it's important to have in their history if they've had an episode of zoster. And also not to confuse it with with other things in the differential, like HSV in a case like this, which is eczema herpeticum. So the take-home point there is that zoster can happen in children, so keep it on your radar. And with the advent of the vaccine, it might change the temporal relationship in the way insurance companies cover Zostavax in the future. Next case is a male with zoster diagnosed last week, treated with antivirals by the PCP, sees derm for skin checks, asked me if he really needs to finish his antivirals because his lesions are resolving. You know how people like to stop everything when they're feeling better. But he's wondering if he should be doing anything else for pain, for acute pain. He's a college engineering professor and has been reading about prednisone and gabapentin, and he prefers that I call him doctor. And this is just to make the point that the acute treatment regimen is important to remember that within 72 hours of the rash appearing, it's appropriate to treat, or if the patient is still developing new skin lesions. So if they're still symptomatic, and because of the safety profile of these medications, it is still appropriate to treat, or if they're at risk or you see any sign of complications, even if it's not acutely disseminated. A week of treatment, and IV for some of the more severe forms. The antiviral medications, I think it's important to always look at costs. So the generics have a huge spectrum, but also compared to their brand name counterparts is listed here. And so I did try to look up the most recent cost profile. Acyclovir is on Walmart's $4 list, but you would need 30. That's only for 30 pills, and so you need 140 of those pills. And so the dosing regimen for that might be a bit clunky. And so it's important to just decide for a patient's particular situation what would be appropriate. We know how these drugs work. Our favorite is usually valacyclovir around where we are at the gram dose 3 times a day for a week, although the other medications are appropriate. The things I put in orange or yellow on my slides are usually my big points, and so you'll see that most of those are in bold. The important reason to treat is because you'll reduce the time that the patient has the lesions, reduce viral shedding and pain. It's important also to kind of dispel myths because from an evidence-based standpoint, it does not decrease the incidence of post-herpetic neuralgia, but there are ongoing studies to show that it might improve the duration of this neuralgia, but the data is inconsistent at this point. And then localized wound care is really your prerogative in terms of where the lesions are, what the patient can tolerate, and topical antivirals are not effective. Then there's conflicting evidence to say, do you start gabapentin? Do you start other medications when you see someone with zoster? The evidence doesn't show that there's a benefit in terms of acute pain, but we'll talk about neuralgia in a minute. But the timing is a bit sketchy, meaning people aren't sure when to start these medications. But if you're talking about pain that the patient is having from the lesions they have currently, there isn't evidence to say that absolutely you should start something like gabapentin. But prednisone is a different story. It does show evidence that it reduces acute pain. And so from a comorbidity standpoint, you have to decide what you're comfortable with in terms of dosing for individual patients for prednisone. But we do that every day with things like poison ivy, and so I think that because it's more of activation of the virus and we're not going to super high doses of prednisone, you have to decide what kind of pain the patient's in. And I think it's important when you see that there might be evolving ophtho or neurologic symptoms to include this. And the dosage regimens, like I said, are a bit sketchy, so you find that people have their own comfort zone of where to put things like TCAs and gabapentin when they do start a patient, and so really it's style-based at this point. So my take-home point for this case was know when to treat and know why, and manage the patient's acute pain. But the next case, you saw her picture in the first slide, is that she's 80. She has a history of zoster 5 years ago, and every time she goes to the doctor, people tell her she has her zoster back. And she doesn't. She has a lot of post-herpetic neuralgia symptomatology, and she constantly scratches her skin. So it's a weak point, a notalgia-type phenomenon where the neurology is really the primary process, but the patient can't keep her hands off of it, so she does get superinfection with different staph bacteria. And at this point, the morphology doesn't really remind you of zoster. It reminds you of trauma. The distribution tells you to dig deeper into what her history is. So when it comes to neuralgia, reduced post-herpetic neuralgia pain is improved with things like gabapentin and pregabalin. Obviously, opioids and TCAs are going to fit into this category as well, but people like the side effect profile of gabapentin. And so my style is to make sure you're following the patient, either to decide to start them on the gabapentin when you see them and decide on an appropriate follow-up, because the definition of post-herpetic neuralgia is more in the first month to 6 weeks if they're having ongoing dysesthesias. But at the same time, to explain to them that you still want to see them just to check things out and make sure they're doing okay. There are combination medications that can be appropriate, including opioids, so it really just depends on what your comfort level is with these medications. And I think your topical and other neurologic-based therapies when it comes to what to do about neuralgia really is more of a multidisciplinary approach, meaning often getting a patient into a pain clinic, neurosurgery, things like that, because the evidence at this point is very anecdotal. So a point with that case is follow the patient out, make sure you know how they're doing in terms of pain and dysesthesias, and manage their chronic pain and post-herpetic neuralgia. Next point is that college professor is back. He calls because he wants my email address because he's too busy to wait on hold to wait for my call. And he's wondering if he should get the shingles vaccine. He wants to make sure he doesn't get this again because he has friends who've dealt with zoster several times. He's still on the valacyclovir, but he also has some extra at home because he gets cold sores. He also wants to know if his wife, who's in her 50s, could also receive the vaccine. I'm sure you get calls like this where people want their entire question base that's in their brain to be answered in one email or one call. So I think knowing a lot about the Zostavax is important. It is FDA approved in 2006 for age 60 or greater, but in 2011 the FDA gave it safety okay for age 50 or greater, and in the EU also 50. But the CDC and the American Committee on Immunization Practices still are keeping it at 60. They declined lowering the age despite its safety profile because of supply and demand, but also they wanted more long-term data. It's a live attenuated vaccine. It's one dose, and we know how it works in terms of boosting the immune system, but it's a very interesting and unique vaccine because it's not going to prevent the first episode of varicella. It's going to prevent reactivation. So a lot of patients will say to me, why would you recommend the Zostavax if it doesn't make my risk of 0, that I'm going to get zoster? And I'm like, it's a tall order. You've already had varicella. So the dosing has to be 10, 15 times what a varicella vaccination would be as a child. And then you have to say, it does a pretty good job actually for what it's set to do. The side effect profile is rather small in terms of injection site reactions, headache, or if you have a true allergy to one of the components, which we'll talk about. In yellow, I have here preventing post-herpetic neuralgia because that sets it apart from some of the other things we've talked about today. Certainly, it has the prevention factor for zoster, which is about 2/3, a little bit more than that. And as you get older, that is a little less. But preventing post-herpetic neuralgia, the 2/3 profile, is what makes it very unique and very helpful for the older patients. And fewer days of pain, less severe presentations of zoster if you do have the vaccination. I tell everybody to get it. I do, everybody. The contraindications are few. Pregnancy at risk, but we're not talking about 50 and 60-year-olds getting pregnant, so at this point, not really something that has to be mentioned. But to talk about people who should not get the vaccine is really talking about the things where you would have T-cell immunodeficiency. So HIV/AIDS patients, talking about some of the cancer patients, high-dose immunosuppressive therapy. And if you're going to vaccinate a patient before chemo, it should be 10 days before or 3 months after they're done. If you're sick, you shouldn't get a live vaccine, active untreated infections, and allergies to the vaccine components, which come up in a lot of vaccine talks, but really they're not talking about contact allergy. They're talking about true allergy to neomycin and the other vaccine components like gelatin. There are no preservatives in the vaccine itself. It's prepared and reconstituted on site that day within 30 minutes. And just from an efficacy standpoint, to answer that patient's question, it has at least 5-year efficacy, probably much longer than that at this point, but they don't know. The studies are still ongoing. And will we need someday a booster is the question as we live longer or if we get the vaccine at younger ages. Now, this percentage is good to keep in your back pocket. The risk of zoster recurrence in a healthy person is only 1 to 5%. So someone always ask when they've had zoster, what is the chance of me getting this again? It's probably around the 2% range. And if they get the vaccine and cut that range by 2/3 of that, think how small that is. And so that makes them feel good. They feel really good when their insurance covers it, but at the same time, it's about giving them numbers to say, well, you've boosted your immune system basically by getting zoster. It's almost like you gave yourself a vaccine. So you at least get probably 3 years out of that getting of zoster to protect you. So people don't have to run out and get the vaccine right when they're done with their valacyclovir. But people still want to. So what you can tell them is that it's safe if you've already had zoster, but you probably could get more bang for your buck if you wait a couple of years. So, there's no side effect or safety profile if you've had zoster with getting the Zostavax, but you probably shouldn't get it while you're still on antivirals because you won't get the response that you want. Or if someone's taking antivirals for cold sores or a prophylaxis for a procedure, let them know they want to get the most out of the medicines they're taking. So take-home point here is that promote vaccination in accordance with the guidelines, but those will probably change. Same professor emails me again, next case, asks about insurance coverage and what will happen with his wife's vaccine, and he's willing to pay for it, but he says money's no object, but he still asks for a coupon. So I think it's important to tell them the logistics of the vaccine and also from an insurance and a cost standpoint what to expect. So in the clinic, which most derm clinics don't carry the vaccine, mostly carried by internal medicine and family practice clinics or from the pharmacies themselves, it's a frozen vaccine that you have to keep stored, and after reconstitution, it has to be given within 30 minutes, so there are no preservatives. I have a 4-year-old, so this is a very relevant slide. The CDC in 2011, though, took a poll that said that only about 16% of people 60 and over are vaccinated against zoster who are eligible to be. So there's a huge underuse of the vaccine, and I think part of it is that no one's quite decided who's going to give it out. The access is really broadening because of pharmacy supplies and because people are realizing that this is an important disease, but I feel like the efforts have not been concentrated quite yet. And then 100% of Medicare Part D plans have it on formulary, last time I checked, and that most private insurances do for patients over 60. The Medicaid plans do vary, and the reimbursement amount varies based on plans, but age less than 60, despite the safety profile I told you, varies between insurances, and there are very few at this point that are covering between 50 and 60. And so I Googled just to see what it would cost if you walked in and said you wanted the vaccine, even if you weren't, if your insurance was not going to cover it, and it's around the $200 to $300 range. And then there are websites to look for coupons and vouchers in terms of helping to pay for it, mostly through Merck itself. So the next point is to know the vaccination cost profile so you can let the patient know if they're eligible, how much it might cost, and that it's being very underutilized, so it's important to go. Because when you saw the efficacy profile and the prevention profile, it's very favorable, and there's very few people who cannot receive it. Okay, the next case talks about psoriasis and psoriatic arthritis patient that's being worked up to get a biologic medication. So what would you tell her about zoster vaccination? Well, since you've learned so much about it, what you say is that their risk with these autoimmune diseases to get a bad case of zoster is very high, and that they might have a longer course, a more severe course, and more of a risk of post-herpetic neuralgia. And so if you're going to start a biologic, it's important to know that you should probably have a month before initiating them that you give them the Zostavax. And you hold it for a month if they happen to get zoster while they're on a biologic. Now, just like when you read articles about when to stop biologics before surgery, the jury's still out about when to stop it so you could give the vaccine and then restart it. And schedule-wise, that can be a little tricky. And so people usually say 1 to 2 doses of the biologic could be held, and then you could give the vaccine. But the 1 month range is sort of the vaccine to restart window. And the safety of the vaccine is similar in these patients, and most recent studies show that probably people could get vaccinated while on biologics, but the studies are still ongoing with larger numbers, and so to be continued there. My guess is that after a while, they'll require that people on biologics do get these vaccines, but they might just keep people on them if they're eligible and turn 60. The other DMARDs, so at lower dosages of prednisone, so less than the 20 milligrams of prednisone a day, and the lower dosages of other immunosuppressives are probably safe as well to give the vaccine without stopping the medications. So next point is just consider zoster vaccine before initiating biologics, because that happens in derm offices all the time. So the last couple of cases are personal. My 80-year-old grandmother calls because she was just treated for shingles last week by her PCP. She wants to know if she can babysit her infant great-granddaughter, and that's my grandma, and that's my daughter. She wants to know if you can administer her shingles vaccine in the living room at our next family gathering. And by the way, can she catch shingles from the vaccine? Like she said, she caught the flu after her last flu shot. And what you can tell them is the virus is present in the respiratory tract, but it is not like it would be if you had chickenpox, where you really need to isolate yourself from other people. And they say it's less than a third as contagious as varicella, but I think it's much, much less than that in terms of what people are actually shedding and what risks they have to others. So in a healthy patient with a classic presentation, we consider standard precautions to be appropriate. But often the lesions are not in areas that are going to be uncovered by clothing, but you cover the ones that would be until they're crusted over. The question is about droplet and contact precautions. Really often when they're getting to the office, we're catching them when the lesions are kind of crusting over and they're feeling better, or they've started antiviral therapy. But it's important to just look at the patient. Sometimes we get to consults and everyone wants to know exactly what are the guidelines and what do we do. You need to look at them, get them undressed, see what's going on with their skin, and then decide how this would be transmitted. Do they work in a NICU? Do they have infant grandchildren? What's the story? And really, if the lesions are covered and the people that they're in contact with have either had chickenpox or are vaccinated against chickenpox, then they're fine. I can't tell you how many pregnant nurses I've seen in units taking care of patients, and they'll get very, very tense. Oh, I'm taking care of someone with zoster. Oh, I'm taking care of someone with an infection. What should I do? Well, healthcare workers themselves are going to have a certain degree of trial and error, but also testing to show that they are immune or they won't be able to work in that institution. So they forget how the virus works. So it's important for you to be the one to tell them. In immunocompromised patients, all bets are off. You're going to do more precautions based on what they have. So it's going to be up to even airborne TB precautions in some people until the lesions are crusted. But don't assume the institutions know what they're doing. If you're coming in for a consult, you're going to be the expert, but you also need to know that the guidelines are to be adhered to with each institution, but you have to have common sense about how it's shed. So can you catch zoster from the vaccine? There's cases of zosteriform eruptions after the vaccine, but they're not culturing out actual vaccine strain. So the answer is no. And there's no post-vaccination wild-type zoster risk that seems to be appropriate. I mean, if you get the vaccine, are you going to get your own case of zoster? And that hasn't been the case. And then do you shed the vaccine strain? And the evidence has been no. So look at each of my cases when you think back and say, how to isolate that patient? What would I do for wound care? And then you'll kind of get yourself more comfortable with how you're going to educate patients about it. So my last take-home point is zoster is very rarely communicable, but know the isolation precautions to be able to tell people what to do, but usually to manage stress. Last case to bring everything all together is a 32-year-old otherwise healthy female, 32 weeks pregnant, ripping pain across the right abdomen for 2 days, followed by a cluster of pink papulovesicles across the abdomen and back, but only on the right side. She's a healthcare worker in an outpatient clinic and visits PCP in her building as a sideline consult after the rash was present for 2 days. What are the issues? So we've talked about all these things. She's pregnant. She's a healthcare worker. She's presenting after 2 days of a prodrome and 2 days of skin lesions, and she's otherwise healthy. So pregnant healthcare workers, as I alluded to before, so healthcare workers in general, have to document that they've had varicella, vaccination, or they've had zoster history or chickenpox, or laboratory immunity proven. So they can't work there unless they've had this. And zoster can occur in any trimester with no increased risk to the mother, the fetus, or the neonate, so differently than getting true chickenpox. And the pregnancy category of the antivirals is B. Some of the pain relief and neuropathy ones are going to be up to C, but mostly B. So what should you do? Should she be treated with oral antivirals? Anybody? What do you think? Okay. Yes, she presented within 72 hours. It'll minimize shedding. She is a healthcare worker, so it'll decrease the risk of shedding to patients if she happens to run into someone who's immunocompromised, but also because she's pregnant, it'll decrease the morbidity during pregnancy. So as we said, antivirals will help with that acute pain and the duration of time for the lesions. Antivirals are pregnancy category B. And also if afterward, if it happens to be at a watershed period, it's okay if nursing. Should she be isolated in any way? She should cover the skin areas. It's on her abdomen and back. Hopefully they'll all be covered if she's working in healthcare. But masked for immunosuppressed or non-immune patients, gloves in certain circumstances. What are the risks to her fetus? Nothing. Maternal immunity to primary varicella has already been established. She's a healthcare worker, but she's been through her normal pregnancy visits as well. And what other treatments should you employ? Localized measures. This is the patient. It's actually a more rotund and cranky version of myself, and I got zoster in my third trimester, so it's me. And basically, I thought that it was that I was just getting too fat too fast because I was getting these ripping pains across my abdomen, but it was just the prodrome for zoster. This was the effect of that gestation. Her name's Natalie, and those are lovely photos, but this is what she's actually like. And she's 4 now. So just to bring it all together to say, clinically, what do you do? Based on pathophysiology, what do you do? And what do you do when it comes to comorbidities? What do you do to manage pain? What are the guidelines when it comes to the medication? What do you tell people about the Zostavax? Consider the vaccine in special populations, and to know how to tell people that this is not necessarily something wildly contagious that they caught. So this is my email if you guys have any questions, and I appreciate your time.